Welcome. Today we're going to cover the cardiovascular system. It's really a bad idea to try to memorize the different morphology or histology of different segments without correlating with the function, with the physiology, with the basic physiology. So I'm going to share with you guys a simple diagram. I love simplicity. And from that diagram, we'll go to discuss the morphology. Sounds like a deal? Okay. The blood leaves the left ventricle, this is the heart, to the aorta, distributes to the different arteries, goes to the capillaries, goes to the veins with valves, to the right atrium, goes to the right ventricle, goes from the pulmonary artery to the lungs. They get oxygen, go back to the right atrium, and then the cycle continues. A little detail corresponds to the circulation of the abdomen. Viscera of the abdomen, such as the small bowel, stomach, spleen, etc., get direct vessels from the aorta, and then capillaries that form the portal vein, which is going to go to the hilum of the liver, branch into a series of capillaries called sinusoids, which are going to form later larger vessels and form the suprahepatic veins close to the inferior vena cava, at the inferior vena cava, close to the heart. It's important to remember that the liver also receives an artery, a hepatic artery from the abdominal aorta, and that blood, arterial blood, is going to mix. The only place in the body where the arterial and the venous blood is mixed is the liver. And then it goes the way I mentioned. Perhaps it's important to realize that the portal vein is strange in the sense that it is a vessel that has capillaries on both ends, which is not very common, not unique, but it is not. It's a little strange. Now, the heart itself, it's a muscle that is involuntary, and we call it a myocardium. So the layers are going to be the endocardium, the myocardium, and then the pericardium or epicardium, which is in other areas is going to be the adventitia. The myocardium, you know about it. It's about short cylindrical cells joined by intercalated discs that have one nuclei, etc. So in the intima, you have some special cells of the conducting cells of the heart. And that's a moment to talk about the conducting system of the heart. The sinoatrial node, there are specific groups of cells that send an impulse that travels to the atria, to the AV node, and then the AB bundle, which divides into a right and a left bundle. And then comes a small series of small branches from that conducting system, which is the Purkinje fibers. All of them tend to be located in the intima adjacent to the myocardium. Like those cells are, for the most part, a little bit have a certain balloon aspect, a certain clearing of the cytoplasm because of the presence of glycogen, have less myofibrils, and they usually get together via gap junctions and desmosomes, and they are surrounded by fibrous tissue and also sympathetic and parasympathetic fibers, which are going to modify the rhythm of the heart. Then we'll go to the aorta, and we'll go to the histology of the aorta. It's easier to think without really meditating about it, that the aorta is going to be has the larger amount of muscle, and the idea is that it doesn't have muscle. It is an elastic vessel, and I actually use the yellow to show the elastic fibers that are concentric around the vessel. We have an intima and some myointimal cells that may acquire lipid and lead you to atherosclerosis later in life, and also calcification. But the elastic fibers can be visualized on H&E, but also on elastic stains. And what is the reason for the elastic tissue in the aorta and these main large branches? Any time that the left ventricle pumps, the aorta is going to receive and then push the blood. It's not going to fight against the heart, so to speak. So that way it's almost like a second heart in the way that it helps give the blood an impulse further. So it's important that it's elastic. And the adventitia has a few little vessels, which we call vasa vasorum, vessels of the vessels, because there's such a thickness of any of these vessels, the oxygen cannot reach and needs a vessel to supply the vessels of the vessels. Gradually, the artery changes. The arteries change from an elastic pattern to a muscular pattern. Why would we need a muscular tissue in those arteries? It's simple, because we need to distribute the blood. We need the body needs to adjust distributing the blood wherever it is more necessary. So here the muscular arteries have several layers of smooth muscle and an internal and external elastic lamina, which may be residual from the elastic tissue from the elastic arteries. And the intima, of course, and an adventitia. As we go along the arteries, and for example, in the case of the small muscular artery, now we lose the external elastic lamina, and we only have the internal elastic lamina. By the way, sometimes you are looking at a vessel and you know if it's an artery or a vein. You sometimes can look at the internal elastic lamina or both, and it helps you to recognize an artery. When you reach the final stages here of the arterioles are really very, very simple. They have 1, 2, or 3 layers of smooth muscle, and an intima and an adventitia, which blends with the surrounding tissue. That's really very simple. Now we get into the capillaries. And the capillaries, I'm going to go back to them in a little while because there's some discussion about it. They just go the saying that the blood branches into an extremely large network of capillaries that are very thin, about the thickness of a red blood cell, which is about 7 microns. So that's the way the gas exchange is made possible, right? We'll talk more about the capillaries later, and the blood goes into the veins. And then the veins, it's important to remember that the pressure from the arterial system doesn't reach the veins. Here, what we have in the veins is just hydrostatic pressure, in the sense that this column of blood has a pressure by itself. For example, like the leg, especially the veins of the leg. And not only does it just have the hydrostatic pressure, but it has the largest amount of blood. And we'll go back to this. Veins contain the largest amount of blood. Obviously, the veins have a semilunar, have bulbs, which protect the blood from going back and that's impossible. That's also the valves, including those of the heart, are relatively easy. They're simple in their anatomy, their structure. Actually, they're actually a folding of the intima with a fibrous lamina in between and a fibrous ring around it. In the case of the AV valves, which are the mitral and tricuspid, the side that is facing the atria has more elastic fibers. But essentially, the valves are very simple and also present in the lymphatics. Now, regarding the veins, I will say something over here. I will say actually that the veins normally have scant amount of smooth muscle. The amount of muscle will grow as in the higher veins, those that are reaching the heart, for example. But the adventitia is quite predominant. And actually, what I would like to say to you is that, for example, when you look at an artery or a vein, usually veins are larger because they have more blood, and they have an ovoid, features or pattern. Whereas arteries tend to be rounded, have less amount of blood, and the muscular layer is more, it kind of is easier to be detected. So actually it's easier to detect the wall of an artery made by smooth muscle, whereas in the vein, it's mostly an adventitia and the vein blends with the surrounding tissue. Those are the easy ways to tell them. Before I go to the capillaries, I'll mention one detail. The portal vein and the inferior vena cava, which are abdominal veins essentially, or retroperitoneal, they have a particular characteristic in which the thicker portion of the vein is conformed by longitudinal fibers, and it's kind of sometimes it's difficult to really realize that we're facing a vein when the muscle layer is so thick. But when you see that the vein, the fibers are going longitudinal in the adventitia, you know that we're dealing with an abdominal type vein, such as the portal vein, for example, or the inferior vena cava. Now, regarding the lymphatics, I will I'll say a couple of things. You know that these capillaries are extremely simple, made by a simple endothelial cell and a basement membrane, and usually have a little attached cell that is contractile, thought to be contractile, called the pericytes. Now, when you go to specific places, such as the kidney or the small bowel or the endocrine organs, we have a fenestrated capillaries in the sense that there are little holes in the endothelial cells. We have a little diaphragm, but that means that those organs need a flow of substances or cells that is more frequent than here. And there's another type of organs in which the basement membrane and the cells both are incomplete and fenestrated, and the flow of cells is much easier. For example, that's the spleen, that's the bone marrow, and that's also the liver. So we have these T types, one a complete, one a normal, a fenestrated, and a completely fenestrated, both the cell and the basement membrane. Now regarding before I go that, the veins, this capillary system is not necessarily that simple. We may have pre and post capillary sphincters that regulate the capillary flow. We may have arteriovenous shunts, such as the one I'm forming here, so that the blood can bypass the capillaries and go from the arterial side to the venous side, and that happens in the skin. Also, another detail is that the veins that are being formed immediately after the capillaries are dilated, and I call the post-capillary venules or collecting venules that are a little bit peculiar because their histology is quite similar to that of a capillary. However, they are more dilated, and apparently they are the site of migration of lymphocytes and other cells because the endothelial cells don't overlap completely, and that would be a place. If you see sections of the lymph node, you're going to see post-capillary venules quite easily. Now, the last detail is what is the reason for us having a lymphatic system? You could say, well, it looks like redundant, right? We have so many vessels in the body, and on top of that, we have another network of vessels that do not contain blood, and just pretty much interstitial tissue, interstitial liquid. So, and the issue is the following. The blood, when it reaches this area, the fluid tends to go out by the hydrostatic pressure is greater here. And then it comes back in the venous aspect because the hydrostatic pressure is lesser. However, there is another force that keeps the blood, tends to attract the blood, is the oncotic pressure. In other words, in the capillaries, we have molecules of proteins such as albumin, proteins that are going to their small molecular weight, and they attract fluid. That means, for example, in a person whose albumin level is very, very low, tends to have edema of the body because of the lack of oncotic pressure. Now, the reason why we have lymphatics appears to be related to the fact that some of these proteins may be leaked to the interstitial fluid, and the only way to get them back is via the lymphatic system. In other words, the lymphatics are very thin, relatively thin. When they grow, they actually have a histology that's similar to the veins, but it's different from them because they don't contain blood, only a fluid that's kind of fuzzy. The endothelial cells of the lymphatics are very thin. The basement membrane is almost non-existent, so the fluid easily can enter the lymphatics. What happens if there is a lesion, there is destruction of the lymphatic system of the organs, which happens in surgery or in, for example, in some certain parasites, for example? Well, in that case, we have lymph edema or lymphatic edema, which if it happens to the axillary lymph nodes, we have an enlargement of the arm, or if it happens in the inguinal lymph nodes, we have an enlargement of the legs in a sometimes pretty impressive fashion. Essentially, this is what I wanted to share with you guys, and I hope that you get something from it. Have a fantastic day.